Great, so it's just coming up to 7. So I've clicked go live just to start the recording. So welcome everybody to today's talks. We'll be covering respiratory, which is one of the main general medical topics. But before we get started, we've got a message from the BMA. So Dan, over to you.
Thanks, Kirsten. Okay, I'm just going to put a little message in the chat. Share my screen. I'm going to share that one. So yeah, just very quickly from me, I was hoping to have a bit of a bigger update for you guys on sort of what's going on junior-wise in the talk. But yeah, don't necessarily have that today, but possibly next week. So there's a bit of an offer on the screen for anyone who's not a BMA member. This is a bit of an exclusive to today. If you join using that link and drop me an email afterwards, you'll get a £10 Amazon voucher. So yeah, just use that QR code or link I put in the chat. Drop me an email after you've done so, detail@bma.org.uk, and I'll get you a £10 Amazon voucher sent over. So it's £3.75 a month for final years. So it's sort of like getting 3 months free, but through an Amazon voucher. So I'm sure everyone knows what the BMA is and what we do. It's obviously been a pretty pivotal year so far, and it's sort of ongoing for us with all the strikes. So essentially, your trade union and professional association. So you may have come across other companies like MDU, MPS. So they're sort of they're indemnity. So it's completely different to what we do. We're sort of the non-clinical side. So things like pay, your contracts. We negotiate all of those things. And yeah, there's 3 ways of looking at it. Really, we look after you not only as a doctor, but also as a medical student. On a national basis, so yeah, things like your contract and your pay, and then locally, so things like when you are sort of next year in your trusts, if there's sort of a collective issue for as an F1, you guys can come to us and we'll sort out any issues, and then yeah, on an individual basis, sadly, the NHS is not the most perfect place to work, and there will be sort of things that arise throughout your career. But yeah, anything non-clinical related, we've got your backs, and we have people that are on the ground in every trust across the country. We usually get answers pretty quickly to things and get things pretty sorted. At the moment, our membership's at 191,800. So you got to remember that that's just medical students and doctors, so it's incredible, really, the backing that everyone's giving each other. Obviously, a union only works if we all sort of pull together, and everyone's seeing that now with the strength of what we're all doing together with the strikes and pushing for better pay. Yeah, like I said, I don't have much of an update. There's been talks for the last few weeks. It's been a bit hush-hush what's gone on, whether they've gone well or not, but yeah, don't be surprised if you sort of hear that we're going back on strike with the juniors sort of, I don't know if it's end of next month or sort of January, but yeah, it's been a bit quiet. So my reckoning is that there may be further strikes soon. Yeah, so just a few tools for you to think about in the here and now. I mean, I guess you guys have heard all about the strikes and what's going on. I hope you're keeping up with that and what's going on with the consultants today. But yeah, I just wanted to remind you that there are other things that the BMA does. So if you're a member, you get access to BMA library. So it's one of the biggest libraries there is. Everything's moved online now. We used to have all the books at BMA House, and you do sort of get them posted out to you and post them back. Now you can access everything digitally, so you can log in bma.org.uk/library. Every book you could ever want is right there, so that'll be helpful in the final year. BMJ Learning as well. If you've never used it, it's got really good revision tools and lots of modules online for you to use. So just have a little play around with that. Clinical Key. I don't know if you've ever used Clinical Key, but if you haven't, download the app and you can log in via your BMA membership. You may have access to it through the med school as well, but there's no paywalls with the BMA version of Clinical Key. So yeah, again, you just type in any condition and it'll bring up every single book, journal, video related to it. So really good point of care tool. BMJ. So now you're in your final year. You have actually got the right to have the BMJ through the post every week, so the physical copy. The thing is, it's an opt-in service, so you just need to give us a call or a quick email and say, look, I'm in front of you, I'd like to get the paper version through the post, and we'll turn that on. It won't be any extra money, so that £3.75 a month will include 4 copies of the BMJ, so they come every Friday, and alternatively, you can obviously switch it off anytime as well. We have a really good wellbeing service. So the unique thing about this is you have the choice of speaking to a peer support doctor, so someone who's been through similar situation. Someone who's been through a similar situation to yourselves, or a counsellor. And if you call us more than once, we'll make sure that you speak to the same person again. Sadly, this is quite a well-used service, but it's that's what it's there for. But yeah, obviously, just come to us if you feel the need to use it. Again, completely confidential of your med school and of the trust you'll be working with. Specialty Explorer tool. So this is quite a unique tool. Good to sort of do this now, maybe a little bit of the way into F1, obviously beyond. It's essentially a psychometric test. It takes about 20 minutes to complete. It'll ask all sorts of work-life balance questions, and then at the end, it will give you a breakdown of the top suite specialties according to the answer you've given. So it's good to start thinking about specialties now. Obviously, you don't have to think too seriously, but this kind of tool, Specialty Explorer, is a real help for that. So that's it. Just wanted a couple of minutes at the start of this to sort of remind you that the BMA is more than the paid campaigns that are going on, and we can help you now. And yeah, and if you're not already a member, definitely join. This is a pivotal moment in the history of junior doctors as consultants as well as SAS doctors. So yeah, the more members we have, the better we are, the stronger we are. I'm going to stop now because my cough has taken over anyway. But yeah, if you're not already a member, join. You get that 10 Amazon voucher if you use that link on the screen. If you go online, you don't get that. So yeah, take advantage of it. And yeah, I'll hand you back to Kirsten.
Hello, thanks so much, Daniel, and that's really helpful for us all to know about. So welcome everybody. It's really great to see so many of you tuning in today for today's respiratory talk. Just to introduce myself, my name's Kirsten. I'm an FY1 doctor on the academic programme, on the SFP programme at St George's Hospital. And I'm currently helping co-lead the final year content of Mind the Bleep, which includes running this revision series. So we really hope that you've been finding it useful so far. There's a couple more talks to go that will lead us into the Christmas and the New Year. At the end of the talk, there'll be a chance to give feedback, and it'd be really great if you guys could all complete that. It really helps us guide the content to what's most useful for you moving forwards for the rest of the year and as we develop the series. And just for those that usually ask, the recordings and the slides are usually available on Medal afterwards as catch-up content, and will also be recorded and uploaded to YouTube as soon as possible. So let's get started. If there's any questions about the content as we go through, please put your question in the chat and I'll try to answer them periodically as we go along. Cool. Can everyone hear and see the slides okay and hear me okay? If you just confirm in the comments before we get started. Everyone able to hear me? Yeah, okay, perfect. Great, so this is an overview of what we covered today. I thought respiratory is such a big topic. I'm going to cover what's most common and most high yield for your examinations. So first of all, we'll talk about lung function tests and then some of the really common conditions and presentations you'll see in MCQs and OSCEs. And this is the MLA curriculum for respiratory. A lot of what we'll cover today will come under this, so hopefully it'll be a useful talk for you all. Great, so let's start off with lung function tests. So we talk a lot in respiratory about FEV1 and FVC. Someone want to type in the comments what they understand, what these acronyms mean. What does FEV1 mean? What does FVC mean? they terms you've come across before? It's all right if you're not. That's okay. Oh, good. Forced expiratory volume. Exactly. So FEV1 is the amount of volume that you can produce on a forced expiratory breath in 1 second. And yeah, absolutely. FVC is forced vital capacity. So that's your total amount of kind of forced breath outwards that doesn't have a defined time period. And that's spirometry is a really useful tool in diagnosing lung disease because it helps us classify between obstructive and restrictive diseases. So with restrictive diseases, that if you picture your lung, for example, in fibrosis or in connective tissue diseases, not able to expand as much as before, then your total forced vital capacity is smaller. However, your FEV1, what you can achieve in 1 second, shouldn't be too much affected because it's the first second. So you usually find that your ratio is normal. So this is common in also neuromuscular disease and obesity, which makes sense because you don't have the kind of strength from your respiratory muscles, accessory muscles to generate a larger forced vital capacity. And then in obstructive diseases, you usually see your FEV1 is markedly decreased, and that manifests as a ratio of less than 0.7. So if you think about your obstructive diseases like COPD, asthma, reversible airway obstruction, bronchiectasis, and cystic fibrosis, these all come under obstructive. So this is really important, and we often use spirometry in, say, COPD to define that it's an obstructive pathology. So let's move on to talk about asthma. So this is one of your most common respiratory presentations, and the key thing to note about asthma is that it's reversible, and this is how we diagnose it, which I'll touch on in a minute. So you've got airflow limitation in your airways, and this is usually due to a hyper-responsiveness of your airways. And you get two types, one which is childhood onset, where you see a younger age of presentation, and this can be due to kind of allergens that you inhale, whereas those who have late onset asthma tend to have it of an occupational nature. And what can precipitate this? Many different things, including house dust mites, dust, vapors and fumes, even infections, cold air, exercise and emotion. And a classic MCQ question is what drugs might precipitate asthma? So you're having a think about NSAIDs, aspirin and beta blockers. That's a really common one. You wouldn't give beta blockers in someone who's asthmatic, they're contraindicated. So asthmatic patients tend to have intermittent coughs, shortness of breath, they have a sensation of chest tightness that they report, and they can be wheezy either audibly if it's severe or on auscultation. You usually see an expiratory wheeze, and they also have a dry cough that's non-productive. So usually if someone does have a productive cough, you want to be thinking more of an infection if it's purulent. And asthma gets exacerbated when they're exposed to these precipitants and different triggers, which can be different for each individual, and also at night time, so you have nocturnal symptoms. And these are questions you'd want to ask in a history of an asthmatic patient to help differentiate between other respiratory conditions. And you also see asthma in patients that are atopic, so they also suffer from, say, hay fever or eczema, or in patients where there is a strong family history of asthma, as there is a hereditary component. So how do we diagnose asthma? So for those who have done their paediatric revision will know that you can't diagnose asthma in children under 5, so usually known as viral-induced wheeze. But for those who are over than 5, we turn to spirometry first. And the key part of spirometry is pairing that tool with bronchodilators to see if asthma patients improve after receiving a bronchodilator. And the test is positive if their FEV1 improves by 12% or more, as well as an increased volume of 200 milliliters or more. So that's a kind of really good way of testing that airway reversibility. And then another way to look at asthma is to look at the fractional exhaled nitric oxide, so the FeNO, and then different values, sorry, it should say 40 ppb for adults and 35 ppb for children. So those are your classic MCQ questions. One thing to note is that your FeNO can be elevated in airway inflammation. It's not just asthma. So it's a good way to kind of pick up asthma, but it's not specific to asthma. So sensitive, but not specific. And FeNO, many people ask, what is it? It's just a way of indicating how much inflammation there is in the lungs. So nitric oxide is a biomarker to indicate the level of inflammation. And so you're testing the levels of nitric oxide in your breath. And then if you're uncertain, you can also add in a peak flow to see how people can achieve it, although it's used only if there's kind of diagnostic uncertainty. And then lots of people, especially patients, always ask this question, what triggers my asthma? So you can use skin prick tests after diagnosis to identify the allergen, but in terms of diagnosing it as a condition, that wouldn't be your first line. So spirometry first and then FeNO is what we'd recommend. And peak flow is a really good way to monitor asthma as well as people improve, not just to diagnose. So how do we treat asthma? So there's kind of a stepping stone treatment as you've come across. So it just depends on first line and then how well they tolerate that or how well it controls their symptoms. And in the community, we aim for asthmatics to be completely symptomless. So those that have a new diagnosis of asthma, we typically start them on a short-acting beta agonist. So this will be like salbutamol for those with newly diagnosed asthma. New guidelines can also say you can start on a corticosteroid inhaler, so inhaled corticosteroids, instead of just SABA. And then you can, again, review the response. It's important to give kind of treatment time to see how people respond. And then if not, you can also add in kind of a long-acting agonist, so like an LTRA. So examples of LTRAs would be like montelukast. So these are leukotriene receptor antagonists. So you've got your salbutamol, then you've got your inhaled steroids like beclomethasone, and then your LTRs like montelucasts. And then if that's not doing great, then you can add in LABAs. So these are your more long-acting beta agonists. So for example, salmeterol, formoterol. There's lots of different names, but if you try remember the acronyms of the mechanism, that's really important to distinguish. And then if you're really struggling on top of that, you can do what's called maintenance and reliever therapy, so MART. So MART consists of an ICS and a fast-acting LABA in a single inhaler, and that is used both daily and for maintenance and symptom relief. So that's a really good way. And then you can step up the strength of your inhaled corticosteroid inhaler based on how well you're responding to the MART treatment. And then if on a medium dose inhaled corticosteroid, you're still not achieving control, then you can probably seek specialist advice at this point. So a lot of this can be managed in a GP community setting, but you want to seek more specialist respiratory input if you find yourself here. So acute asthma. So when a patient with asthma finds themselves very breathless, and this is a medical emergency situation, it's really important to risk stratify between this. So this is a medical emergency, and this is when an asthma is not responding to salbutamol. There's worsening shortness of breath, cough and a wheeze, and it's often an infection that might trigger this all. Something that's really important to consider is an ABG, because that will help guide you in terms of their oxygen and CO2, because when someone has an asthma attack, they often get tired of breathing really heavily, and that becomes really dangerous when they get exhausted. So when someone has a normal PA CO2 on their blood gas, that starts to become worrying and life-threatening. And then, for example, if they start to retain CO2, that means they're not blowing off carbon dioxide and they're getting even more tired. So that's near fatal, and that's where you want to escalate as soon as possible. So yeah, I pretty much put a table summary of all these different values that are really important to learn for an MCQ question. You can look at their peak expiratory flow rates, their respiratory rates, their heart rates. It's really important to get accurate observations on your acute asthmatic patients. And then on examination, what might you see for an acute asthmatic patient? You see reduced chest expansion, a prolonged expiratory phase, and bilateral expiratory polyphonic wheeze. It's really typical in asthma. So yeah, always do an ABG as a first line assessment for asthma. And initially you'll see respiratory alkalosis as you hyperventilate and blow off CO2. And then as you become acidotic, that becomes more concerning because you're retaining that CO2, as I mentioned. So these are patients that tend to need admitting, and a classic MCQ is when to admit these patients. So if someone's got features of life-threatening asthma, or after initial treatment they still have severe asthma, or they've previously had a near-fatal asthma attack, or they're pregnant, those 4 criteria are reasons to admit patients overnight into a medical team for acute asthma. And then how we go about treating acute asthma. So you start off with salbutamol inhaler and oral prednisolone. Initially 4 puffs and then 2 puffs every minute. And then if that doesn't work, you can consider driving the salbutamol with a nebulizer with oxygen pushing it in. And also if they've got an oxygen requirement, always start acutely unwell patients on 15 litres of oxygen and then titrate down. You can also consider ipratropium, so nebulizers as well. And then at that stage, you'd want to escalate to a senior. If there's still poor response with your ipratropium and salbutamol nebs, you can consider things like magnesium and theophylline as well, or escalating to ITU. So it's really important with asthma as it's a life-threatening emergency to escalate as soon as possible. Great. So I've got a MCQ question for you guys to practice. So to pop your answers in the chat. So you're sitting in on a respiratory clinic and you've been asked to review a patient's spirometry result. Sheila is a 52-year-old woman who was referred by her GP for spirometry due to symptoms of worsening breathlessness on exertion and a chronic cough productive of white sputum. She has a 60-pack year smoking history and her daughter has told her she thinks she has lost weight, but she hasn't noticed herself. Her spirometry results show an FEV1 of 1.9, predicted 2.94, and an FVC of 3.48, predicted 3.52. What is the most likely diagnosis? So pop your answers in the chat. Cool. Getting a lot of Bs, so that's really good. Can someone comment why they think it might be B? Why have we gone for COPD? Smoking history, absolutely. Significant smoking history. Low FEV1. Yeah, good. So those are your 2 main clues, is that this is an obstructive picture and someone has a heavy smoking history. And if you also look at their age, 52, you're less likely to come across lung cancer for the first time or less likely to come across asthma for the first time if there's no occupational risk factors. Good, well done. So yeah, let's move on to talk about COPD. So COPD is chronic obstructive pulmonary disease, and it's an umbrella term for 2 features. So there's chronic bronchitis and emphysema. And that's another classic question and really important to know, is how do we go about diagnosing someone with COPD? It has to be obstructive in nature, and you have to have these elements. And so the most common cause of COPD is smoking. And in younger patients or those without a smoking history can be alpha-1 antitrypsin deficiency. But can really be any kind of respiratory exposure. So for example, chemicals, fumes, dust, pollution, they all can contribute to a COPD-like picture. Symptoms of people with COPD is they have chronic shortness of breath that gets worse and worse. They often have a cough that's productive, wheeze, and are more liable to recurrent chest infections. And if it's severe, you can often see pursed lip breathing as people try to generate positive pressure in their airways with pursed lips, and poor chest expansion. Investigations, as we said, we diagnose this with spirometry, and on chest x-ray you would see hyperinflation, so you see flattening of the diaphragm and you see an increase in the number of ribs seen on chest x-ray that would suggest hyperinflation. And then you'd also want to send off sputum cultures for patients with COPD. As we'll touch on later, they're more likely to get recurrent chest infections and grow kind of more weird and wonderful bugs than a patient who doesn't have respiratory disease. And that will help guide antibiotic management. So your follow-up question is, you have calculated Sheila's FEV1 to be 65% of predicted, and an FEV1 to FVC ratio is 0.55. What is the severity of COPD based on this? This question's a little bit harder, but we'll talk through the answer. Moderate, good. So Bayern's gone for moderate. So this is how we classify COPD. It's based basically on FEV1, FVC ratio. And then on the right-hand column, I've put in some symptoms that you might expect to see. So as you can see, as your FEV1 gets smaller and smaller of the predicted value, you get increasing breathlessness, and it can be even at rest in people with very severe COPD. So this is a really important staging criteria to remember. It's all based on FEV1, and then also on the condition that their ratio is less than 0.7, because that proves an obstructive picture. So yeah, this is just a classic MCQ question. It's worth remembering, so I put the table in for you for revision. So how do we manage COPD? So given that most people get COPD from smoking, the first thing we would do is advise smoking cessation. And does anyone want to put in the chat methods that they know that could aid patients with smoking cessation? So this is something we do day in and day out on a respiratory ward. We have a lot of patients with smoke histories. Exactly, so nicotine patches are kind of our mainstay to help people kind of quit smoking in an acute setting, as well as say like nicotine inhalators or nicotine lozenges. They can be really effective too. So initially what we would do is start with a SABA, so a short-acting beta agonist, or a SAMA, so short-acting muscarinic antagonist, like ipratropium. And then if you have persistent symptoms or exacerbations, you can add in a long-acting beta agonist and a long-acting muscarinic agonist. And then the thing to remember is, if a COPD patient presents with asthmatic features, or they are eosinophilic, or they respond to steroids, you can also consider adding an inhaled corticosteroid that we use in asthma patients. And then for patients to prevent COPDs or prevent infective exacerbation COPDs, we can think about rescue packs of antibiotics at home, a pneumococcal vaccine, the annual influenza vaccine. These will all help prevent, and can also think about with patients with frequent exacerbations using azithromycin as prophylaxis. And then another thing is, you can offer pulmonary rehabilitation for everyone who feels affected by COPD, feels that their breathlessness is hard to manage. That's really effective. And for those really struggling, you can think about long-term oxygen therapy. So these patients will have oxygen cylinders at home and can administer themselves oxygen to relieve their symptoms. And this can be indicated if they have a PaO2 of less than 7.3. or if they have a PaO2 of less than 8 and they have either one of these features on top, so secondary polycythemia, peripheral edema, or pulmonary hypertension. So these are all really useful tools for someone to manage their COPD in a community setting. Obviously, long-term oxygen therapy is contraindicated in people who still smoke, but it's something worth thinking about for severe COPD patients, and you would use a ABG blood gas to help guide whether they qualify for LTOT treatment, say long-term oxygen therapy. So a really common presentation in an acute hospital setting is acute exacerbation of COPD, and this is often a bacterial or superimposed viral infection in a patient with COPD. The most common bacteria you'll see would be Haemophilus influenzae, and also Strep pneumoniae and human rhinovirus as a viral cause. Your patient will come in with increased shortness of breath, present with a cough, sputum, wheeze, and be hypoxic and have low saturations. They also might have acute confusion in the context of acute illness, and the complications would be respiratory failure. How do we manage this? First of all, we're going to get a chest x-ray to look for other respiratory causes, look for any consolidation that might be from the infection. And we'd also do an ABG to help guide us if they're in respiratory failure or if they're struggling to oxygenate. If they're hypoxic, we use oxygen. Don't forget with COPD patients, if they are retaining CO2 on their blood gas, that shows they're a chronic carbon dioxide retainer. And we like to aim lower in our saturations in these patients because the hypoxia is actually a drive for these patients to ventilate. And so we want to aim 88 to 92 deliberately. And you can start off with 15 litres, but if it's a COPD patient with chronic hypercapnia, you can use Venturi masks as well to help adjust the oxygen delivery. And then in terms of treating the exacerbation, you go for salbutamol and ipratropium nebulizers is really common, and also add in oral prednisolone for 5 days. And then if you feel they are infective, depends on your microguide at each local trust, but we'd go for doxycycline as a broad enough antibiotic cover. And other useful tools to treat infective exacerbations are chest physiotherapy to encourage the expectoration of sputum, and also BiPAP can be considered for patients with worsening respiratory distress, so with a resp rate of over 30, or if they find themselves in respiratory acidosis on their blood gas, so they have a pH of less than 7.35, and they've failed to respond to optimal medical treatment, then we can think about aiding ventilation, non-invasive ventilation. Cool. I hope that all makes sense so far. I've got another MCQ for you guys. So 63-year-old woman presents to A&E with confusion after a fall. She has a productive cough and is short of breath. Her respiratory rate is 32 and her temperature is 37.8. Her heart rate is 90, her blood pressure is 85/65, and her SATs are 94% on air. Chest x-ray reveals right lower zone consolidation, and blood results come back with a urea of 8. What is this patient's CURB 65 score? Again, another classic MCQ question. And just pop your answers in the chat. Cool. So we've got a few different answers here, some 3s, some 4s. Let's give you a few more people to put their answers in. Again, more 3s or 4s. People change their mind. Okay, cool. So the answer is C, is 4. So let's have a look at the breakdown of the criteria of CURB. So CURB 65 is super useful, helps kind of aid how we treat patients, whether they should be treated in the community or they should come into the hospital, and helps tell us the severity of their infection. So this is for pneumonia patients, very classic chest infection. So they present with shortness of breath, they might be febrile, have a productive cough, and have some pain from all the coughing, so pleuritic chest pain, or also kind of pain in their lower zones if the consolidation and infection is in one of the lower lobes. On examination, you would expect reduced air entry, crackles on auscultation, and also reduced expansion of their chest. And then there's different ways you can classify a pneumonia. So it can be community acquired versus hospital acquired, which is the onset of a pneumonia 48 hours after hospital admission. And there's other types of pneumonias too. So you can think about aspiration pneumonia. So if someone developed a pneumonia after kind of choking on food from an unsafe swallow or aspirating on their own saliva, or is it atypical? And that refers to the bugs and organisms that have caused it. So for community-acquired pneumonia, you would turn to curb 65. So confusion gets you 1 point. It's also important to establish the patient's baseline confusion, because in lots of patients, they have some background level of confusion already. Bloods, so using these will tell you the urea, so greater than 7 gives you another point. And then OBS, so respiratory rate over 30. So if they're tachypneic, that'll give you another point. And then B is for blood pressure. So if their systolic is less than 90 or their diastolic is less than 60, and they're hypertensive, that will give you another point. And then age, increased age also puts you at risk. So if they're over 65, that'll give you another point. So yeah, our patient was 4 out of 5 on the curb scale, because they were 63, so they had 1 less point from 65, but they had rest rate of 32, and they had blood pressure systolic of 85, and they also had a urea of 8, and they also presented with confusion after a 4. So that's why we've got a score of 4. And then this little table is something really useful to learn in terms of MCQs about common organisms in pneumonia. So for a typical CAP, you see strep pneumonia is your most common bug. And then in COPD patients, it's worth thinking about Haemophilus. And you might also get a superimposed influenza viral infection over a bacterial component. And the other atypicals include Mycoplasma, that you can look for in the blood, and also Legionella, which you want to look for in the urine. In those with immunosuppressed patients, you want to think more weird and wonderful bugs, so like Pneumocystis jirovecii, Aspergillus, Pseudomonas, and cytomegalovirus are more common. And then when you go into a hospital-acquired pneumonia, Staph aureus, Klebsiella, and Pseudomonas are all your more common bugs. And then you can think about your enteric gram-negative bacteria too. And then if the MCQ stem has some occupational risk factors, think about chlamydia, psittaci, contact with birds, and Coxiella burnetii is contact with farm animals. So one to remember. So for CAP, how do we investigate pneumonias? So thinking about chest x-rays, just going to look for consolidation in someone with pneumonia. And then you want to do blood. So you're looking for your infective markers like white cells and CRP, and then your urea and electrolytes, and then also send off blood cultures. And it's really important to do this before you start antibiotics so that you have accurate blood results. You do an ABG if you feel there's background respiratory disease already, or if they have low saturations, they might have trouble oxygenating. You want to do your atypical screen, as I said, so Mycoplasma antibodies, urine Legionella, and also pneumococcal antigen. And send off sputum culture, again, ideally before antibiotics. And then you want to do a flu swab, so respiratory viral panel, and of course, COVID and influenza swab, just to rule out a superimposed viral infection. And management really just depends on the guidelines. So at my hospital, with curb 0 to 1, you can start with oral doxycycline or amoxicillin. Curb 2 to 5, you want to go in something a bit stronger. So IV benzalpenicillin and oral doxycycline. So doxycycline helps cover your atypicals. And then if they present with sepsis and you're not 100% sure on the source, because it's hard to be in an acute medical setting, you can start off with IV comoxiclav and gentamicin, and that will be a really broad cover for chest sepsis. Great, so that's everything about CAPS. Very, very common example, and that you will see in a hospital and in your exam questions as well. So let's move on to talk about pleural effusions. So pleural effusions is an excessive amount of fluid in the pleural space. So if I just swap to the next slide, this is an example of a chest x-ray that you will see a pleural effusion. Normal pleural fluid volume is around 30 millilitres, but to be able to see it on a chest x-ray like this is around 300 millilitres of fluid, and to be detected clinically, so if someone's symptomatic of it, it's usually 500 millilitres. There's lots of different causes of effusions that we'll go through, but if someone's having a massive effusion, they're most commonly malignant in origin. So how do pleural effusion patients present? So if you just think about how would you feel if you had lots of fluid in your lungs, so you'd be short of breath, and you have a dry cough and chest pain, and on examination on the side you've got pleural effusion, so they can be unilateral. You'd have reduced expansion, stony dullness on percussion because of the fluid, reduced breath sound, and reduced vocal resonance. And to investigate is chest x-ray. You see the meniscus sign and the blunting of costophrenic angles, as you can see here. And you see this dense homogeneous shadowing that looks like fluid, and you can actually see the fluid level quite well on the right, and then you can see the meniscus sign as well on the left. And then you can actually see fluid in the fissures, so in between the different lobes you can see fluid as horizontal lines in the right, in the middle zone of the right lung. And then to investigate pleural effusions, doing a TAP, so taking some pleural fluid assisted by ultrasound, is diagnostic. So you want to look at the appearance and then send it off for protein, LDH, so lactase dehydrogenase, glucose, pH, and cytology for malignant concern, and microbiology for infective concern. So that's really helpful in diagnosing the cause. And that also helped us classify, by looking at the protein, whether pleural effusion is transudate or exudate. So if it's less than 25 grams a litre of protein, that's transudate. And if it's over 35, then it's exudate. And the pathophysiology is transudate means that the hydrostatic forces are pushing out fluid into the pleura. So it's usually bilateral, whereas exudate means there's a damage in the pleura causing fluid and protein to come out. So it's usually unilateral, which makes sense. If it's in the middle, we use what's called Light's criteria to try and differentiate. So if effusion protein to serum protein ratio is over 0.5, that suggests exudate, or effusion LDH to serum LDH is over 0.6, or effusion LDH is greater than 2/3 of the upper reference limit of the normal serum LDH, then it would also suggest exudate. So these are just kind of ratios you need to learn, and they're very classic MCQ questions on how to classify transudate versus exudate, and that will also help us point us into the direction of the cause of the effusion. So transudates are usually caused by, I always think of it as heart failure or liver failure or kidney failure, so nephrotic syndrome. So low albumin or heart failure, and also hypothyroid and Meg syndrome, which is an ovarian fibroma. Can also cause pleural effusions, something to bear in mind. And then for exudate, it's usually caused by lung cancer, pneumonia, some rheumatological conditions, tuberculosis, and different drugs can also cause it. So methotrexate, amiodarone, phenytoin, and nitrofurantoin are the ones to remember. And if it's transudate, then you obviously have to treat the underlying disease that's causing it, because these things like heart failure and liver failure won't self-resolve, whereas with exudate treatment is often draining the fluid off in the hope that you, for example, can treat the pneumonia or the tuberculosis as well, and the effusion will resolve. Okay. If anyone's got any questions as we go along, just pop them in the chat. But let's move on to talk about pneumothoraxes. So again, really common. Hopefully you guys can see the chest x-ray here. A pneumothorax is basically just defined as air in the pleural space. So on a chest x-ray, you can see that there's a gap between the ribs and the edge of your lung field, which we shouldn't see essentially. And that leads to either a complete or a partial collapse of the lung. And chest x-ray is the best way to diagnose a pneumothorax. Unless it's a tension, then you should never see a chest x-ray of a tension pneumothorax because you should have treated it before waiting for imaging. You can classify these into primary and secondary. So primary is also known as spontaneous, and that usually occurs, so typically in young men. Tall, thin young men is your typical OSCE patient. As a result of a pleural bleb, so you just develop a pneumothorax. Or in secondary just refers to the fact there is some kind of underlying lung disease. And we can also classify it into small or large, small being less than 2 centimeters at the hilum. And we can also classify it into simple versus tension. So in tension, the tear in the pleura acts as a one-way valve. So you just get increasing amounts of intrapleural pressure, and that can lead to cardiorespiratory arrest because there's just air coming in continuously. And that's why you need to treat it urgently because it's life-threatening. Cool. So how do we know if someone has tension pneumothorax? Is that they'll have tracheal deviations. It's really important to examine the trachea in a respiratory exam, not just auscultate the lungs. They have a mediastinal shift. So you might find that the apex of the heart has shifted. You have tachycardia and you're hypotensive. So you're hemodynamically unstable. So how do we manage tension pneumothoraxes? Oh, we'll come on to that. So let's talk about how we manage simple pneumothoraxes first. So if there's no symptoms and it's a small pneumothorax, you can do no treatment and follow up in 2 to 4 weeks' time. They're symptomatic with shortness of breath, or it's a large pneumothorax. And what you do is a needle aspiration, and you can also consider a chest drain. Or if they're unstable or bilateral, you can just jump straight to a chest drain. So this diagram is a really useful schematic of remembering your management of spontaneous pneumothoraxes. So is it primary or secondary? And then look at the size, and then you can aspirate it and then discharge if that's successful in a primary. If it's secondary, if it's small, you can aspirate. You wouldn't just leave it and monitor in a secondary. You'd always treat. And then if it's large, you can go straight in with a chest drain. But yeah, these patients often need close monitoring because you can get recurrent pneumothoraxes easily. So you've got another MCQ here. So a bubble wrap-like texture is palpated under the skin of the neck during the examination of a patient with a chest trauma, which is diagnosed as subcutaneous emphysema. Which of the following signs would further support a diagnosis of tension pneumothorax? I think, first of all, which way your trachea will deviate, and they would appear on their OBS. Would they be stable? What would it affect? Good, so lots of answers saying D. Great, so tracheal deviation away, absolutely, away from the affected lung because there's collapse. And there's also hypertension and hypoxia. So they're hemodynamically unstable and they're struggling to oxygenate and breathe. So absolutely hypoxia. Great. So how do we treat tension pneumothorax? You want to go into the triangle of safety with urgent needle thoracocentesis and intercostal tube drainage. So you put the chest drain into this triangle of safety. So that's between the lateral edge of the pec major, the fifth intercostal space, and the lateral edge of the latissimus dorsi. And we call this the triangle safety because it's the safest place to insert a drain. And it also gives you good access to the pneumothorax. So yeah, hopefully you do a chest x-ray after you drain to check the resolution of the pneumothorax. But yeah, people always say tension pneumothorax is a chest x-ray you should never see, because if you have clinical suspicion of a tension pneumothorax, you treat straight away, you don't organise imaging, or you don't wait for imaging to confirm your diagnosis. Well done. So the next MCQ is this. A 77-year-old female patient presents to her GP with shortness of breath that has developed acutely over the past few hours with a stabbing chest pain. She was discharged from hospital 8 days ago with antibiotics following an episode of diverticulitis. On examination, she is tachycardic, 104, tachypneic, respiratory 27. And in addition, her right leg is swollen and her calf is tender on palpation. The GP arranges for the patient to be admitted. What single intervention will confirm the most likely cause of her acute breathlessness? ABG, chest X-ray, CTPA, ECG, or D-dimer? Good. CTPA. So lots of these are very valid, and one could say you'd want to do all these things in someone that you're suspecting a PE. But you would want the single investigation that will confirm the most likely cause. So CTPA is diagnostic, and that will reveal the pulmonary embolus. So well done. Okay, so pulmonary embolus is usually a clot in the pulse. So we've just had a question. We just thought I'd answer it quickly, going back to the tension pneumothorax. And someone's asking, they got taught to aspirate from the second intercostal space in the mid-clavicular line. So you'd use that for kind of needle aspiration or needle thoracentesis. If you're putting a chest drain in, you want to go into the triangle of safety, which is in your fifth intercostal space, mid-axillary line, triangle of safety. So needles go into the second intercostal space, mid-clavicular line. Drains, it's like tubes, go into the fifth intercostal space. Hope that clears it up. Cool. So moving on to pulmonary embolism. So it's a clot in your pulmonary arteries, and that impairs your blood flow. These clots usually arise from thrombi in your DVT, so basically your DVTs in the iliofemoral veins. So small embolus can kind of affect your peripheral pulmonary vessels, and it actually can be silent if it's small, unless it causes a pulmonary infarction. Then you get symptomatic, so shortness of breath. And then you get this VQ mismatch in PEs because of impaired gas exchange. And then in very large PEs, you obstruct your right ventricular outflow, and this increases the resistance in your pulmonary, so in your lung vessels, and then you can actually get right-sided heart strain and acute right heart failure in this picture. Symptoms can be really vague, and not every patient presents the same, but things to look out for are shortness of breath, cough, hemoptysis, and pleuritic chest pain. And if it's a massive PE, they might be hemodynamically unstable as well. Risk factors. So our patient in the MCQ had risk factors because they had an recent operation, so recent surgery puts you at risk of PE. And after their surgery, I imagine they would be more immobile than usual, so that also puts you at risk factor. Other things are long haul flights, pregnancy, estrogen, so thinking about people on hormonal treatment or the contraceptive pill, people with malignancies, polycythemia, lupus, and thrombophilia are all important risk factors to remember. And the investigation, so ECG was mentioned as one of the options. Very few people actually have this classic S1Q3T3 finding, so having S waves in lead 1, Q waves just before your complex in lead 3, and inverted T waves in lead 3. So it's not great. You do a chest X-ray just to exclude other pathology that would contribute to your shortness of breath and chest pain. But usually in someone with a PE, their chest X-ray will be completely normal. You can use D-dimer. It's got high sensitivity, so almost everyone with a PE will have a high D-dimer, but not everyone with a high D-dimer will have a PE. So D-dimer is raised in a lot of different settings. So it's got poor specificity. It's something good to guide treatment to rule out PE, but it's not good because it can be elevated in pregnancy, malignancy, post-operatively. It's not great. But the best thing to do is a CTPA. So you give a bolus of contrast in your veins, and then you can capture the flow through pulmonary arteries. Although you can still miss small embolus with CTPA. And then in patients who can't have a CTPA, so for example, they've got kidney failure and contrast needs to be cleared by the kidneys, or they're pregnant, then you can do a nuclear medicine ventilation perfusion scan to look at the mismatch between ventilation and perfusion. And an important thing for deciding on clinical management for PEs is having a look at a Wells score. So if someone has a Wells score of more than 4, then you go for a CTPA straight off the bat, or if they have a Wells score less than 4, then you do D-dimer first, and if that's positive, then arrange a CTPA. So do they have signs of a DVT? Is PE your top differential? Are they tachycardic? Do they have this immobility or surgery risk factor? Do they have previous personal history of clots? Did they have hemoptysis? And do they have a background of malignancy? So how do we manage PEs? So if they're hypoxic, give them oxygen and give them analgesia to manage their pleuritic chest pain. And then once you suspect it, don't wait for CTPA treatment, just start treatment straight away. So in a hospital setting, we would start someone on treatment-based dalteparin, so a higher dose of dalteparin, the low molecular weight heparin, because there's no point in waiting if you already think, if you've got clinical suspicion, then you should just go for it, and then you can change it back to a prophylactic dose afterwards. Because often things like CTPAs in a hospital, depending on what hospital you're in, can take quite a long time to organise. So just start them on high dose molecular weight heparin. And then when we discharge them, we usually commence them on a DOAC because that's a lot easier because they're oral tablets and take them once or once twice a day. So apixaban or rivaroxaban, most common ones. You can also give warfarin, just depends on the patient's background and preferences. In terms of how long you treat someone, if it's provoked and you've got an identified risk factor, then just 3 months. Or if it's unprovoked, then you want to treat them for longer because you don't know what the cause was, say 6 months. And including if it's active cancer, because the risk factor of having a PE will kind of remain in the background. So with cancer patients, it's all really dependent on their treatment plan, if they're having active treatment or it's palliative, or what the kind of risk-benefit ratio is of carrying on anticoagulation. Treatment can be lifelong if patients do come back with recurrent clots. And in patients who have an unprovoked PE, you might want to consider screening for malignancy. So, for example, doing a CT abdo-pelvis to look for causes of a PE. They might have an undiagnosed malignancy. And then another treatment option is if you do have a massive PE and you're hemodynamically compromised, you want to resolve that clot quickly. And the best way to do that is thrombolysis with intravenous alteplase, first a bolus and then an infusion. Great. So I think this is the last section of the talk. So one last MCQ. So Paul is a 64-year-old man. He presents to the medical admission unit with increasing breathlessness over the past year. When asked, he states he smoked socially back in the day, and he also reports that in the past 6 months, he has lost a stone and a half. Sorry, lost half a stone. He last travelled abroad in 2021 to visit his daughter in Australia. On examination, he has finger crackles and fine crackles by body. What is the most likely diagnosis? Is it COPD, lung cancer, sarcoidosis, idiopathic pulmonary fibrosis, or heart failure? What do you guys think? Great, well done everyone. So lots of people have gone for D, idiopathic pulmonary fibrosis. So I want to talk about ILD. ILD is an umbrella term describing lots of different kinds of lung diseases. That the key thing is that there's bilateral diffuse lung changes that leads to lung fibrosis. So it's a fibrotic picture. And it looks like, in terms of a clinical picture, 3 C's. So I always think cough, clubbing, and coarse crackles is how an ILD patient would look like. So these patients usually have poor prognosis because fibrotic is not really a reversible condition. So there's different ways to classify, or different groups of interstitial lung disease. So you've got your idiopathic pulmonary fibrosis, you've got rheumatological conditions. So if they've got rheumatoid arthritis, lupus, Angst-Bond, Sjögren's, polymyositis, they can all present with ILD as well. Can be drug-induced, so important ones to remember: phenytoin, amiodarone, methotrexate, and nitrofurantoin. Can be occupational, asbestosis and silicosis, hypersensitivity pneumonitis, so thinking about farmer's lung with mold and bird fanciers, looking at their occupational risk factors. And it can also be granulomatous, so thinking about sarcoid, tuberculosis, and GPA vasculitis. So yeah, as I said, cough, shortness of breath, malaise, weight loss, crackles. And then in terms of what caused the interstitial lung disease, always try to think of it as anything inhaled. Tends to be upper zone fibrosis. So things like TB, hypersensitivity pneumonitis, occupational. The only exception is asbestos. And then anything that's caused from the bloodstream tends to cause lower zone fibrosis. So idiopathic fibrosis, drugs, rheumatological causes, and the only exception is Angst-Bond, where you get like apical fibrosis. So that's another easy way to help differentiate between upper and lower zone fibrosis. How do we investigate these people? So we look at blood tests. So we want to look at autoimmune screens to think, is there anything rheumatological going on or vasculitic? They'll have increased inflammatory markers with their CRP. And the ABG might show a type 1 respiratory failure. So it's worth doing a gas on acutely unwell respiratory patients. Their spirometry, as we said before, will have a restrictive picture, so reduced forced vital capacity and hopefully a preserved ratio. The chest X-ray will show bilateral pulmonary infiltrates and what we call reticulonodular shadowing. And then on CT, this is your classic sign to remember for MCQs. It looks like honeycomb. So it's what we call ground glass appearance, which is kind of increased grey matter. And then you also get the honeycomb with the fibrosis. So you can do lung biopsy as well, but it's not often done in practice. And then how do we treat this? Treat the underlying cause. So if it was a drug, withdraw the drug, avoid the allergens, treat the rheumatological disease, but it's often just supportive therapy. And there's not a huge amount we can do for patients with this disease. For the one thing to say is that if it is hypersensitivity pneumonitis, we can trial oral steroids and further down the line immunosuppressants, because these do show a response. And then the more new class of drugs called DMARDs, disease-modifying drugs. There's no conclusive evidence about it, but you can use it in select patients. So you might have heard of pirfenidone. It's a novel antifibrotic to try reverse some of the pathology, although it's not exactly proven. And then also you can think about this tyrosine kinase inhibitor called nintedanib to try reverse some of the pathophysiology. So that's everything I wanted to cover in this talk today. Again, put your questions in the chat if there's anything I might have missed out. And here's a QR code to put in any feedback. And our next talk will be next month on Thursday. So every Monday and Thursday we've got a talk. And then we also want to start introducing some OSCE content. So I'm just going to share my screen with you again, because I just want to really quickly talk through how to go through a respiratory exam at the end. And then if you guys could put in the feedback if you think OSCE teaching virtually, so over medal, would be useful for you guys or not, then let us know. Okay, so for a respiratory examination, as you start with every examination, you want to inspect your surroundings. So have a look at the table on the ward, what medications do they have on the table, how are they sitting, how are they breathing. Look at the patient. Are they in respiratory distress? Are they coughing? Do they have audible wheeze or stridor? And then always start peripherally. So looking at the hands, look for clubbing especially. So 5 C's are the 5 causes of clubbing. So there's different causes of clubbing. So 5 C's is one of them. So clubbing can be, as we said in our last case, from fibrosis. Look at the colour of the hands, look for any cigarette tar or any yellowing of the fingers. Can be cancer, or you can also look for a CO2 retention flap. These are your 5 C's of clubbing. And then look at the arms. So have a feel of the radial pulse. What's their heart rate like? And whilst you're having a feel of the radial pulse, take a look at their rest rate, but don't tell the patient you're looking at their rest rate, because it will change the way they breathe. So if someone says they're looking at the way you're breathing, you're often either hypo or hyperventilate, so you want to do it distracted. And then you want to look at their face, look for any pallor in their conjunctiva, and then you can look for other signs in the eyes, like facial plethora in someone who's a CO2 retainer. And then look in their mouth. Are they clinically dry? Or are they well hydrated? Do they have central cyanosis? Do they have any kind of cyanotic mouth or tongue? Look, 4 things to look at in the neck. So feel their pulse, lie them back 45 degrees, and look at the JVP. That helps with fluid balance. And then, as we said before, tracheal radiation can be really important. And then have a feel for lymph nodes. Again, looking for any kind of cancers or any reactive lymph nodes from infection. And then look at the chest. So first of all, start by having a look. Any scars from surgeries, any skin changes? Are they hyperinflated? Do they have a barrel chest like in COPD? Do they have a particular breathing pattern like a seesaw breathing pattern? And then palpate. So put your hands around the chest and then measure chest expansion, have a feel for the apex beat, look for any right ventricular heave, any right heart strain, which is common in lung pathologies. Then percuss both anteriorly and posteriorly, and then auscultate anteriorly and posteriorly. Would always recommend, if you're short on time in an OSCE, to do just the posterior, because you can access the lung fields and hear them a lot better, but it's good practice to do both sides. And then you can test vocal resonance by getting the patient to say 99. And then have a look at their legs. Do they have any pitting edema? Might suggest heart failure. They've got tender calves, that suggests DVT. You can look for skin changes like erythema nodosum. And then once you've worked your way around the whole body, it's time to present your patient. And then to complete your respiratory examination, you want to do some basic tests. So SPOT-X is a really good acronym for respiratory patients. So you want to do a sputum sample and culture. That will help guide antibiotics. Peak flow that's indicated, for example, an asthmatic patient. Want to do oximetry to check their saturations, temperature if they're febrile, if they've got an infection, and of course, chest X-ray to look for pathology. So I hope that's helpful. I'll stick around and keep having you keep an eye on the chat questions, so if there's anything people want to clarify. But otherwise, please fill in the feedback. I'll put a link to the feedback form in the chat, or you should receive it automatically. You should receive it automatically when you kind of come off this talk as part of MEDAL. But yeah, thank you so much for attending. And yeah, I hope to see you at further talks. Thanks, guys.